What are the current guideline recommendations supporting the management of HCC by endovascular management?
Yeah, the current guidelines is we can use the conventional TACE, that is the endovascular route, conventional TACE or a drug-eluting TACE or a TARE in an intermediate stage B. This is the actual guideline, and you can extrapolate the guideline as mentioned before, that whenever the patient is not an ideal candidate for an ablation or a resection, and the waiting period for both of or the transplant is more, then you can think of a TACE. TARE actually is a two-stage procedure. The stage one will be where you will do the mass scan, what we call it, to see the lung shunt fractions. Suppose if it is less than 20%, then the dose calculation will be done depending upon the perfused volume and the tumor volume, and which will be delivered according to the doctor's recommendation as to how he wants the dose to be given, and it will be arrived according to the prescribed dose about a week to 10 days later, and then we do the second session. So in TARE, basically it is relatively a daycare procedure. Although even TACE is considered to be a daycare procedure, but still we do keep the patients for 1 or 2 days post-procedure. Whereas TARE, you can go the same day to the home with relatively lesser side effects. To be precise, less than 1% what we have seen.
How does this intervention change the course of patient journey during the management phase?
The intermediate stage B patients who are presenting usually will be a large HCC, sometimes multinodular HCC, in whom transplant he may be not be viable for a transplant because of his age or because of his deranged liver function, or in spite of being a liver function very good, the patient may not be willing to undergo a transplant due to some other logistics in view of the age or whatever. If a properly superselective TACE or a TARE been done, they have undergone a subsequent resection / transplant. So whenever you do a TARE or a TACE, you need to follow up the patients with, at the end of first month and then third month, with cross-sectional imaging, preferably triphasic MRI. That is MRI with contrast of the liver. In TARE, you can expect the results up to 3, starting from 3 and even up to 6 months. The success of a TACE relies on one thing is you need to selectively, super selectively or selectively catheterize and embolize ensure that you embolize the complete tumor, whatever is in question. And then subsequently you follow it up with MRI. So then you will be able to see the follow-up whether there is complete response, partial response, poor response, or no response.
What is the message you would want to give to the general physicians about managing the patients in their OPD after this novel management by TACE has been done by an interventional radiologist?
There will be mild rise of AST-ALT, which we do prognosticate the patient and not to worry. So preferably he should avoid constipation, to take care of the pain with local analgesics. Ensure that if there is any significant rise in ALT, AST, or suddenly he has developed significant ascites, then he needs to refer back to an hepatologist. Preferable whenever we do a transarterial radioembolization, to wait for the response to happen at least between 3 to 6 months, preferably 3 months.